Shall I start?
Yes, please.
Okay, so good morning all the
Set the timer, please. Yeah.
Good morning all the judges, chairpersons and all the other presenters and speakers. I am Dr. Vishwendra SISODIA, and on behalf of VST Center for Glaucoma Care, Shantilal Shangvi Cornea Institute and LV Prasad Eye Institute, Hyderabad, I would be presenting the first paper. The title is Comparison of Eye Care IC200 and Goldmann Applanation Tonometer for Intraocular Pressure Measurement in Post-Keratoplasty Eyes. These are the abbreviations which I would be using along my presentation. Post-PK glaucoma, as we know, is one of the common causes of graft failure and loss of vision in eyes which have undergone keratoplasty, and it is critical to estimate and pick up intraocular pressure elevation in the early post-operative period. Now, there are various challenges in measuring intraocular pressure in these eyes because of the presence of thick and edematous graft, presence of astigmatism because of sutures, and presence of bandage contact lens in the early post-operative period. Now, before coming to the purpose of this study, why we plan to start the study is because we used to see a lot of patients being referred from the cornea clinic post 3 months or 6 months or even 9 months of transplantation who used to have advanced disc damage, and when we go back to the records, we used to see that the pressure was checked with eye care, over BCL, without BCL. So that's why we did this study to compare the IOP measurement obtained using eye care IC200 and GAT in post-keratoplasty eyes and assess the IOP with and without presence of bandage contact lens. So it was a prospective cross-sectional study conducted between June 22 to May 23. We included eyes with minimum 4 weeks post-keratoplasty, absence of ocular pathology other than glaucoma. The indications for keratoplasty were keratoconus, corneal opacity, dystrophies, bullous keratopathy, previous graft failure. Both clear and edematous grafts were included with and without BCL. We excluded eyes with active ocular infection, central scarring or bullae which can preclude GAT IOP estimation, and eyes with previous VR surgery. We also included the normal controls. So we included, as you can see here, eyes with DALC, with DMEC, with DSEC and post-penetrating keratoplasty. And as you can see in these OCT images, there is presence of BCL over all these grafted eyes, and if you can see, there is a presence of tear film between the BCL and the graft, which could also give fallacious reading of intraocular pressure. So we used eye care IC200 and Goldmann Applanation Tonometer, and the bandage contact lens which we use is the silicone hydrogel contact lens. So first the IOP was measured with eye care over the BCL by the first examiner, then the BCL was removed and again the IOP reading was taken with eye care. 5 minutes later another examiner measured the IOP with GAT without BCL. So there were total 52 control eyes, 59 eyes which underwent full thickness keratoplasty, 44 eyes which underwent DMEC or DSEC, and 33 eyes which underwent DALC. So as you can see here in this bar diagram, in the control eyes in which the IOP was checked with eye care with BCL and without BCL had an overestimation of IOP as compared to GAT. These are the normal control eyes. Whereas PK eyes had underestimation of IOP with eye care both with BCL and without BCL, and similarly underestimation of IOP was seen in EK and DALC eyes as well. These are the Bland-Altman plot analysis of the control eyes, of the PK eyes, of the endothelial keratoplasty eyes and the DALC eyes. So if you can see the difference between the eye care with BCL versus GAT, in the control eyes there was overestimation of IOP, whereas if you can see the difference between eye care versus GAT in penetrating keratoplasty, endothelial keratoplasty or DALC eyes, there was underestimation of IOP. Now you would say that statistically significant difference is not there, but here rather than talking about the p-value, the relevance is more of clinical significance. If you take any case-to-case basis and analyze these patients, it is very important to rule out glaucoma, that the glaucoma should not be missed, and these patients should be promptly treated and in adequate time as well. So my take clinic message is that the eye care IC200 tends to underestimate the intraocular pressure in post-keratoplasty eyes, whether full thickness or lamellar. It can lead to underdiagnosis and suboptimal management of glaucoma in these patients. Therefore, careful consideration should be done while choosing tonometry methods in these patients. Thank you.
Hello. Can you tell me one thing regarding applanation tonometer? In case of keratoplasty, there will be a lot of astigmatism. How did you go about in these cases?
Sorry, I didn't get your question.
In keratoplasty cases, the sutures are already on. Even if it's not the on, there'll be a huge astigmatism.
Yes, yes.
So how did you go about taking IOP in these cases with Goldman ablation tonometer?
So as per if in high astigmatism patients, the guidelines which are there to do applanation tonometry that were followed, which are given in
And
Whitaker's.
which guideline? That's what I want, because you've not mentioned here.
Okay, so according to the Whitaker's article, there are 3 ways which you can measure.
I'm
IOP.
not asking how many ways are there. I'm just asking what method did you apply? Because you have not mentioned in your article.
So first the IOP is checked in the horizontal axis, then the applanation prism is rotated.
I'm not asking is checked. I'm saying what did you use? Which method did you apply?
So this method we use. First we measured the IOP with the prism at the horizontal axis, then we rotated the prism, and then we measured the IOP at the vertical axis, and then the average of these IOP were recorded.
Yeah, just one question. You are taking Goldman as the standard in such cases.
Yes.
And Goldman can be fallacious in such cases also.
Yes, yes.
So,
exactly.
so what made you think that under the reading that was, that was lower in eye care was wrong and Goldman was right?
So what we have seen in our patients and also clinically, that though Goldman might not give the accurate estimation of IOP in patients with any form of keratoplasty, but still the IOP measured with GAT is much more reliable as compared to eye care.
Which method would be the ideal in such cases?
So I would say that if there is no epithelial defect, I would still go for Goldman applanation tonometer over eye care or over any other form of tonometry.